go and lose any more time.
Great, thanks, Chandni. So for those of you who don't know me, I think I've attended one of these forums previously. My name's Adam. I work at Kingston GP Chambers, and we've sort of developed now a new kind of consultancy and training wing of the Federation, which is CQC Assured, which offers kind of mock inspections, training, consultancy, and all the rest of it. And Chandni has kindly invited me along today to just provide you with an update of sort of all things relevant to pharmacy colleagues working in primary care. So bear with me a second. Okay, so just give you a quick overview about what I'm going to be talking about today. So first of all, just give you an overview about what CQC says about pharmacists working in general practice. Very importantly, this is a key area now. And I mean, I suppose really this is, I would say, more relevant potentially for your employers than it is for yourself. It's really the requirements around sort of oversight of those of you who are non-medical prescribers as well, people who are employed through PCNs. I will give an update around the Arden's search. I've just got a slide which shows you what the, sorry, I think someone's,
could everyone please mute themselves, because we are obviously trying to make sure that everyone can hear what's going on. Otherwise I'm going to have to name and shame, which we don't want to do on that front. Also, what I'll say, Adam, is I'll keep an eye on the chat, so if any questions come up, I'll bring them up to you at the end.
That's great, thanks, Jenny. So yeah, oversight of non-medical prescribers, sort of the requirements around that, what CQC expects to see, the sort of issue with kind of PCN employed staff and sort of who's responsible for what when you're employed from a by PCN potentially, but you're working within practice. As I said, there's a slide just giving you kind of the overview from Arden's about what the updates are and on when they happened, which I'll circulate this afterwards. It'll probably mean a lot more to you than it does to me. I am not a clinician, so I have no sort of real awareness of what they're talking about half the time. And then in terms of the work that we've been doing at CQC Assured, so we have GP SPIN fellows, I was mentioning to Chandni briefly, who are now supporting us on mock inspections, running the Arden searches, reviewing records, and sort of the themes that are coming up from those records reviews. I will say, you know, to bear in mind, a lot of the issues that we find are probably more from our GP colleagues, from the sort of management of medicines, than they are from pharmacy colleagues. These pharmacy colleagues tend to be much better with sort of documentation and other things, but it's worth, you know, bearing this stuff in mind, and, you know, potentially you can feed this back to others in your practice as well.
Can I just intervene just quickly? Please. With the GP SPIN fellows, are they doing like a mock inspection, like how a GP CQC inspector would come in and interpret those results? And what is a GP SPIN fellow for people who haven't heard of that?
A GP SPIN fellow is someone who is essentially, they're sort of contracted out to learn about kind of management or other kind of, it's sort of a development opportunity for GPs. It's kind of to I think sort of foster, develop the sort of primary care leaders of the future potentially, and they can choose like different areas, different projects to kind of focus on. So we've got someone working with us who's getting a bit more information about CQC, and is supporting with the rollout of these mock inspections, and from this kind of developing hopefully tools and resources that can support practices and those who are, you know, running Arden searches, but also other kind of clinical aspects of the CQC inspection process as well. So they are employed by us at the moment for a session a week, and they will come in, run the Arden searches, and then review a selection of records in line with what CQC would do on an actual inspection. Great. Okay. Super.
Thank you.
Okay, so this again is more the sort of obligation for the people who are registered with CQC, so the practices you work in, and depending on whether or not they need to be registered, your PCNs potentially as well. So what CQC says about pharmacists, pharmacy technicians working in general practice, to meet the regulations, provider must ensure that pharmacy professionals have the skills, knowledge, and experience to deliver effective care and treatment, work within the scope of their qualifications, competence, skills, and experience. This is sort of a key thing that keeps coming up on inspection now. Receive support, training, and professional development, including supervision and appraisals. And practices must ensure that staff meet these requirements, even if they do not employ their pharmacy professionals directly. So this is particularly important because, you know, you're all working across primary care networks. You might not be directly employed in practices, but the responsibility for having this sort of assurance has to come from somewhere. So either the practice is assured that the PCN are doing it, or vice versa. It's the practice's responsibility. But I'll talk about that more on subsequent slides. So this is a real now hot topic at CQC, is the oversight of non-medical prescribers, including prescribing pharmacists. So even though pharmacy professionals have been working in general practice for quite some time now, recently CQC are really taking a closer look about what specifically what you're doing, and kind of more importantly how this is overseen. So again, from CQC, GP practice and pharmacists must agree the range and extent of their prescribing practice. The practice must be sure and have evidence that the pharmacist is competent in those areas. So first of all, evidence of competence. So this is really, as I say, more relevant for your employers, but I'm just sort of telling you guys in the hope that you can feed this back, because it is coming up all the time now. So evidence of competence, first of all, obviously your qualifications. Do your employers have evidence, and are they asking you for evidence that you are qualified to be able to do the job that you're employed to do? Secondly, and very importantly now, a clearly documented scope of practice, which kind of clearly lists what you can do and also what you're not able to do. So if the scope of practice is very narrow, it's easy to say, they do this and nothing else. And obviously you might have certain categories of patients that you maybe don't consult with, and these exclusions should also be documented as well. So, if you're not consulting with under 5s or whatever, I know this is sort of was for advanced nurse practitioners an issue for a while. And if your documented scope of practice is very broad, then unfortunately the document will need to be more extensive and probably need to clearly state what you can do as well as what you can't do. Important to note as well is that if your scope of practice kind of expands during your employment, then the practice should have evidence that you have the competency in any of these kind of expanded areas as well. So in terms of evidence in that, which we'll go into in a second, they should have a documented sort of assessment, supervision, audits, and have updated the scope accordingly based on that evidence that they have that you're now competent in those areas. Next 2 points: documented supervision sessions and audits of prescribing. So, Chandni, I'll take your question now as we go. Anyone else as well, just throw your hand up.
So I've had a couple of texts come through on that front. So I think some people are a little bit shy, so they're just texting, which is fine.
Yeah, that's fine.
So question is, so obviously our employers need to know that we have evidence of competence, but they're going to ultimately come back to us to say, how do we know that you're competent? What evidence can you show? So what kind of things should we be gathering in order for that, to be able to go and show that?
You should be qualified to do it. And again, this sort of, you've got the qualification, you sort of set what you are able to do and you feel competent to do it. And then it's these next parts that kind of provide the evidence then that you are actually competent to do it. So you're having your supervision sessions and that they're undertaking audits, particularly if you're, for non-medical prescribers, which is related to audits of your prescribing. So they should be auditing. And I would say, CQC will not give you a clearly defined time frame or frequency for auditing. So what I've been recommending to practices that they do is kind of, when someone's initially employed, maybe do like a monthly audit of their prescribing. Once you have confidence that their prescribing is appropriate in accordance with guidelines, you can sort of expand that frequency to quarterly. If you want to expand it further thereafter, you possibly can do, but you would really want to have good assurance and evidence that you're satisfied with their prescribing. So, supervision sessions that are documented where they're sort of sitting in consultations, and then that audit of prescribing is very, very key, so that they have the assurance that you are doing what you should be doing and are competent to do so.
So different courses. So if we so I remember from my lovely CQC inspector, God help him. So when he came in, he actually asked me to see like different certificates of different courses and things. So it's worth us going and keeping maybe a portfolio for the CQC inspector to be able to show the things that show our competence.
Absolutely. Yeah, exactly. So that all goes back to your sort of qualifications, is that, if you've done additional courses that are giving you enhanced sort of skills that you're now employing in practice, absolutely keep those as key pieces of evidence to demonstrate that competence. So that plus, your scope of practice, which sort of adheres to what you're trained to do, plus then the sort of effectively safety net and looking at your prescribing and doing sort of oversight and supervision sessions, that altogether is kind of the evidence that you are, fit and appropriate to be, prescribing and also just providing care for the practice. That'll sort of meet the CQC's expectations and requirements.
Absolutely. So if we, for example, we've all done, as a pharmacist, we have to do a master's on that front, which gives us a good generalist knowledge. But then if in the particular areas where we're going to be prescribing in on that front, we need to be able to prove competence. So just writing, say, long-term conditions in itself, we need to go and actually have a bit more grit to it. So what else have we done on top of that to keep on top of being able to prescribe in those areas? Yeah,
exactly. And I would say, long-term conditions, if you're talking about scope of practice, that will not be enough. You'll have to sort of be a bit more detailed and say, I'm qualified to do sort of asthma reviews. I've got sort of diabetic, all the sort of relevant areas that you're looking at. It needs to be kind of broken down in a bit more granular detail, unfortunately. And I think the problem with this is that a lot of inspectors don't really know what the expectation is. And they're sort of, I think a lot of them kind of making it up as they go. So in order to kind of avoid any questions or any issues, the more detailed that you can make it, the better. And I have seen instances where, they've looked at a scope of practice, they've then reviewed consultations and find that people are prescribing outside of their scope of competence as well. So it is really important that whatever is documented actually aligns with what you're doing in practice as well. And I'll talk about that probably extensively in the rest of the session as well, but that's a really key point.
Perfect. I'll let you carry on because I thought that was really important, because that's something that I know has been picked up in another CQC inspection that didn't go quite well. So I thought it was just important just to bring it up.
Yeah, no, absolutely. So again, auditing or prescribing, sort of the more confident your employer is about your skills and your ability to prescribe safely and effectively, that you can increase the frequency, reduce the frequency potentially of those audits. And then this is something that came up on a recent inspection as well. There needs to be kind of a tool that reception are using to book patients in with you, which also aligns to the scope of practice as well. So reception need to be confident that they know exactly what it is that you do and don't do. CQC don't like it if you're incorrectly booked in with someone and then have to be understandably diverted and wait for another appointment as well. So that's a key thing to know. So
and the other thing I'd probably add in, if you don't mind me saying, Adam, is because it's a very relevant question to this, just come into the actual chat as well.
Oh yes,
but actually non-prescribers as well, you'd expect some form of similar evidence for say medication reviews and things that they're doing to show that they're competent in reviewing those particular patients as well.
Yes,
on that front.
I agree, and I always advise this as well. It doesn't seem to be something that CQC are necessarily looking at to the same extent, really. I think it's they seem to be just always worried about the provision of medicines, which is understandable. There's sort of a higher degree of risk potentially, but for my mind, and it's the same with kind of physicians associates, which I won't get into, but really, physicians associates, it's like, well, we don't need to do anything because we always look at what they're, we have to sign off their prescriptions. But what about the patients who don't have a prescription? What if they've sent those patients away incorrectly and they actually did need something else or something done? So I always think it is good practice for those who aren't prescribers as well. The practice should be doing reviews and supervision sessions as well. Absolutely. And CQC will potentially expect to see that. But the importance is, in terms of what's going to result in a really bad inspection, is there's no mechanism to oversee non-medical prescribers. But absolutely, Chandni, you raise a good point, is that, yes, it should be really across the board. Not necessarily, obviously, the audit and a prescribing, but there should be supervision sessions and reviews of records and all the rest of it as well.
Amazing. Thank you.
Yes, so, okay, that's fine. I think I've covered everything on that slide. Okay, and then PCN employed people, it's also an area CQC are looking into quite extensively, and I'll go through this sort of short list, but really what there needs to be is clear lines of responsibility and effective feedback mechanisms in place around performance. So despite maybe you being a PCN employee, if you work in a practice and you see those patients as part of that practice provision of CQC regulated activities, then you are really, the practice are really responsible for ensuring that that pharmacy professional, regardless of who they're employed by, is working in accordance with CQC regulations. So, some of the things to think about if you are PCN employed, and sort of feedback to your employer if this doesn't sort of ring any bells of what has been done since your time working there. So, who does the recruitment checks? Again, not so relevant for you guys maybe on the call. Again, it's really targeted at your employers, but it's something that comes up quite often on inspections. So if you're employed by a PCN, the employing practice should either have access to your recruitment information and some assurance that these checks have been done, or some assurance that the checks have been done prior to your employment. And I think the danger often with relying on assurances from PCNs is that often CQC will go up to a practice who is regulated and is being inspected, ask for all this information. They'll go to the PCN who've said, oh, we've done all the recruitment checks, and half of them won't be there. So, I mean, there is a bit of a risk with relying on assurances. So I just wanted to really highlight the CQC will not care that the PCN, is responsible for not doing the checks. Ultimately, the practice is regulated. They're providing the regulated activity. You're providing that regulated activity there. They are responsible for ensuring that you are suitable to be employed in doing that. Who is responsible for defining the scope of practice? Now, is it the PCN? Is your scope of practice potentially different depending on what practice you are working in and what they're happy for you to do? And therefore, well, you might need sort of individual scopes drafted for each practices depending on what they're happy for you to do. So it's something to think about. Again, I'll touch upon this probably in the later thing, but it's, do you have it as individual practices are sort of overseeing these non-medical prescribers and sort of our staff? Or is it better to kind of consolidate everything and have consistent processes across a PCN patch or federation patch? So next point is around supervision, appraisal and auditing. So how is this done? Is it done centrally by the PCN, which is fine, but there needs to be, again, a mechanism for each of the individual practices you're employed by to contribute to your appraisal and sort of have assurances around prescribing of non-medical prescribers in particular. So again, all can be coordinated centrally, but you need to be feeding back into that, and it doesn't sort of negate the responsibility for the practice to be kind of doing kind of auditing. It can be, they can, if you're all on EMIS and you are able to access lists of patients where prescribing's been done or consultations have been done, and that sort of auditing can be done centrally at the PCN level, that's absolutely fine. But it can't be just, a centralized audit that focuses on practices 1 and 2 and misses out practice 3. All of it needs to be included, and all practices need to be feeding into it. And then different roles and different practices. So which policies maybe are you following in particular? So picked this up on a few inspections. So there'll be a pharmacist working maybe in 4 practices, helping with high-risk drug monitoring and prescribing. All practices have slightly different policies in place for the management of high-risk medicines and other drugs. And the pharmacy professional is just following the process of practice A, or just often just doing something completely different that doesn't align with any of the policies. So, what I've seen, frequently is that you go out, you ask the pharmacy professional how they're managing high-risk drug monitoring. They say, oh, I'm following this process, which is the process of practice A. I've gone in to inspect practice B and pulled up their prescribing policy, and what they're saying just does not align with it. So, and again, what I would say is this an area that potentially could be coordinated across the PCN? Could you have a single centralized high-risk drug monitoring process that covers all the practices, so that you guys essentially don't have to think, all right, I'm in practice A today, what is it that they're expecting me to do, and then practice B tomorrow, and still having to kind of refresh your memory about what exactly it is that they want you to do as well. So these are just some points to note that have come up quite frequently on previous inspections, and also when we're doing these mock inspections now. So, Arden's update, I've just created a slide which actually gives you kind of a breakdown of exactly what has been updated on each of the Arden searches. So I'm going to circulate this afterwards because I'll be quite honest, I am not a clinician and I don't really know what any of this means to any great level of detail. So over to you guys, you can work that out afterwards, but that is the overview. And what I would say about the updates with Arden searches is that every time you're running the Arden searches for your practices or what have you, make sure. Is that a question from someone?
No, I think someone just joined. Don't worry, I'll mute them. If they haven't muted themselves, I will mute them. Don't worry.
Okay.
There you go, muted. You carry on.
So yeah, as I say, every time you're running the Arden searches, make sure that you're using the latest version. Now, I prepared this presentation a few days ago and it was 2.4. So if it's not right now, I apologize. But as far as I'm aware, it's version 2.4. And yeah, I just thought it would be useful to include this kind of overview of these updates. And I'll send these across to Nisha and Chadney to circulate afterwards. So again, I'm not sure, as Chadney said before, all of the changes are significant changes for you guys. But I think sort of the most kind of major change was back in January 23, but there's been obviously a few tweaks and additions since then. Okay, so, and yes, final couple of slides. So CQC searches, the themes and trends that we've now picked up using our GP SPIM fellows on these mock inspections. So this is across several boroughs in South London, and the learning points that we're getting from these, or the sort of issues that are arising, are kind of consistent across the board. So it's sort of things that I think will be generally helpful for all of you. First of all, timeframes for monitoring not aligning with the parameters of the searches. So make sure that all staff are clear about what the search parameters are, and that your recall processes within your practice kind of align with these timeframes and are initiated at such a time that you're able to get the patient in, get the monitoring done before prescribing or issuing prescription, sorry. Not following practice policy or inconsistent application of policy. So I sort of touched on this before, but this is kind of relevant to all practices, but again, particularly challenging for pharmacy colleagues employed via PCNs who, as I mentioned on the previous slide, are working under different policies. So ideally, standard process across PCN. I'm not telling you to do that, but I'm just telling you it does seem to be much easier. And yeah, essentially, what CQC will always be testing, a huge part of their inspection is what is documented and what is happening in practice. So, if you are working in various practices at the moment, ask to see their prescribing policy, look at what it says, and does what it say align with what you're actually doing, or is there some sort of inconsistency there? If there is, raise this with whoever within the practice and seek clarification. Does what you're doing need to change to align with that policy, or should the policy be updated to be reflective of what you're actually doing in practice? So yeah, always what they're testing is documented policy versus what they can see on the system and happening in practice. Next point is records not indicating that monitoring has been reviewed. The sort of results from monitoring haven't been reviewed before prescribing. So results can be, often contained in letters on other systems. However, if these aren't explicitly referred to in the patient record before prescribing or issuing the prescription, then CQC might take the view, and this has happened on inspections, it's sort of different. GP advisors will take different views on this. I think there's one who is very specific about it being sort of medical legally sound. So really, if the monitoring has been done and it's in another letter, you should really be transferring that into the patient's record and showing at least a consideration of those results before you're making the decision to issue a prescription for these types of medication, particularly high-risk drugs. Lack of detail in medication reviews. So, medication review codes and EMIS is not enough. So make sure that the review was done in consultation with the patient where appropriate as well. That often comes up on inspection. So people just putting through codes, issuing medication, hasn't actually been a medication review. And again, as I said at the start, this is generally, and I hope no GPs are on the call, it is more of a GP issue, not really sort of a pharmacist colleague issue. Often Pharmacy colleagues have very, very detailed and thorough reviews noted, and GPs, I would say, less so. So yeah, that's probably less of an issue for you, but it is something that CQC will look at. It does come up on when we're doing these record reviews, so just to make you aware of that. Inappropriate modality of consultations and assessments. So a lot of telemedicine used in circumstances where physical in-person assessments would be needed or more appropriate. And I think, you know, this is potentially kind of an immediate hangover from the pandemic, and it's maybe less of an issue now, but it still kind of comes up often on these inspections that we're doing. Safety net and advice not provided following MHRA alerts. So CQC will look to see if appropriate counselling is being provided to patients concerning the risks stemming from certain medications following the issuing of MHRA alerts. And we found during these reviews that, you know, that isn't happening sometimes, and not happening at sort of regular frequency that's often required. So make sure that you're aware of the frequencies, make sure you're aware of the counselling. I mean, it's all fairly clearly set out in these searches, and make sure that that counselling is being given. And quite often, I've had a lot of pushback from GPs about this, saying, well, you know, it's not really appropriate for this patient to receive this regular counselling. CQC sometimes just do not care about that. And I think, unfortunately, I agree with the practices sometimes, or did when I was doing this as an inspector, that really, you know, there's certain contexts where it's unlikely that this person is going to get pregnant or, you know, whatever else. And it can be quite distressing to have this repeated conversation. But regardless, CQC seem to not really care and say, you know, there is a potential risk, however remote it is, and therefore that counselling should be given. And then lack of documented rationale for continuing to prescribe high-risk medicines in absence of monitoring. So if patients don't attend for monitoring and you decide to prescribe in absence of that monitoring, there really needs to be a clearly documented rationale for doing so. You know, for instance, off the top of my head, this patient's been stable for years. The risk of, you know, not giving this patient their medicine is far greater than sort of, sorry, what am I trying to say? So you know what I'm saying, the risk of stopping it, the risk of harm is greater for stopping it rather than continuing in absence of monitoring. And again, the practice prescribing policy, which it never really does, should also outline this kind of process for managing patients who fail to attend for high-risk drug monitoring. So there should be kind of, you know, are you short scripting these patients? Are you, and you know, if you are short scripting them, what then happens after they still repeatedly fail to attend? How many issues on a short script do you give? Things like that. So yeah, it just all needs to be clearly documented. And again, the process needs to follow what's happening in practice. So that's my little bit about the themes and trends. I've got one more slide, but I noticed there was a few questions.
We've had a couple of things coming through, so I thought I wouldn't interrupt your flow if that was
no,
all right.
No, go for it. Go for it. What's
so the first thing was that the practices used to get a quarterly list of all the items that were prescribed by independent prescribers. Haven't seen that for a while, and do you know how we get this? I've already answered that you can get that through EPAC 2. So if you haven't had a chance to read the message, I've put it in the chat that actually Medicines Management used to do this, but with the big restructure happening at the ICB, they aren't actually going in passing those out. So if you sign up to EPAC 2 for your specific practice, you should be able to then download that for any non-medical prescriber who's within that practice, as long as you're granted access from your GP lead from that practice in itself. And then you can then get that up yourself for your own prescribing as well as for anyone else. The other option you've got is creating a search if you want something before that first kind of 3 months, because what you get is 3 months in arrears of what is cashed in effectively from the pharmacies. If you want something in itself for your own prescribing practice of what you're prescribing, say, in the last month, you can create a search, which is quite easy to do. I've created one for all of our allied healthcare professionals, God help them. So one of our GPs, actually, bless him, he'll go through and he'll pick some random prescriptions that someone has prescribed and check if it's appropriate and within their scope. So that's something that we do in our practice already. So if someone needs those searches, I can see if I can export it on that front. The only problem with that is that will normally go and have the person who's your user on them. So you'll have to change the user for each one and have it for each individual person. But I don't mind circulating that if that would make it easier, because that was something I did post our CQC inspection, because that was something that we picked up. Simon's put a very good point, saying, would it be possible to share good practice with the GPs in the surgery so they understand how the searches should be used? Because some of them are using them to catch up all patients to pick them up, rather than having them as a process already to identify those people who are at risk. So my understanding is that the CQC searches should be a safety net, but some practices are then relying on them now just to as their routine recall, if that makes sense. So is that something that can be shared then with GP practices and with PMs probably, so they can put a process in place?
I mean, absolutely. I think we do sort of regular updates for Kingston and Richmond, certainly. I'm not sure about the rest of South West London, but I'm happy to maybe sort of attend any sessions that are available for GPs there. But certainly we have I mean, I can't tell you how much I've been banging the drum about these for so long. And again, I think that point is a really good point, Simon. I think I've just been banging so hard to say, like, do the searches, CQC are coming for the searches. Whereas, yeah, you're absolutely right. There's sort of a foundation, if you like, of what you should be doing for the sort of highest risk areas. It's not the sort of catch-all for everything and then just leave everything else.
I agree. And
yeah,
I think that is something, and I hate to say it, in a certain area that you're governing is also an issue there, I think, as well as the wider South West London team, because I feel like the pharmacists are getting a brunt of it and they're having to pick up the pieces on that front. So I think it may be just worth maybe just giving them a poke and saying they need to be a robust system. These are safety net searches on that front. If that's okay from your side.
I would, you can take that from me if that helps, you know, when you go and speak to your employers, is that, you know, the guy from CQC have said that is as at a minimum. Sure, it's all that CQC are looking at on inspection, but it's not necessarily the way you deliver excellent patient care, is just focusing on these and nothing else. So yeah, but any contact that I have subsequently, I'm absolutely happy to raise that point. I think that's something that I haven't really thought about. I'm always just so CQC focused that but you raise a good point, Simon. Any other questions?
Nothing else in itself, and nothing that's been sent to me by text. So you carry on, my love.
Okay, I've just got one more slide. So this is really just what CQC will potentially ask you about on inspections. So, you know, it'll be role dependent, obviously, but some of the things that they could ask you about are kind of particularly like processes. So they'll be asking you, you know, what they'll see is a documented policy. They'll ask staff about the process, and then they will look at the records, and that kind of triangulates evidence for them, as saying, okay, you've got these three things here, and do they all kind of match up and align with one another? So the processes that you might be asked about are, you know, medication reviews, medicines reconciliation, if you're involved in that, the processes for supervision and appraisal, and how you get kind of feedback from those exercises and prescribing audits as well. Processes for high-risk drug monitoring, obviously, and safety alerts, again, sort of ARDENS, CQC ARDENS type bits and pieces. Antibiotic and controlled drug prescribing as well. So this is an area of focus, and really the practice should be undertaking periodic audits of that sort of independent to cover, you know, the entirety of the practice, not just pharmacy colleagues, but GPs as well, to make sure not. And I think a lot of times we go to practices, we say, oh, what's, you know, have you done any auditing of antibiotic prescribing? And they're like, oh, well, the ICB gives us information and it says that we're kind of broadly in line with other practices. That's not what CQC are after. What they're looking at is the appropriateness of those prescriptions. So you might be in line with everyone else, but, you know, you could be prescribing a load of rubbish that doesn't need to be dished out. And the same with controlled drugs as well.
On that one, please make sure you go and use the RCGP toolkit. You can do an audit of your antibiotic prescribing in a particular area to prove competence and prove that you're actually prescribing correctly. You don't need to do all of them, but you can pick up one. So the one that I've done is the UTI in simple, uncomplicated UTIs in a woman who basically in women who normally get them, and making sure they're 3 days duration, the right dose, and so forth. I don't need to go through all the detail, but you can use that. It's got a really nice template on there. You can actually got a data capturing tool, and it works really well. And that way you're showing that actually we are auditing our prescribing as well as we are prescribing appropriately, and this is showing that.
Yeah, absolutely. Oh yes, involvement in QoF. So again, CQC are not really that bothered about QoF anymore. They used to just look at this and look at exception reporting and all the rest of it. I think the Arden searches have broadly replaced their focus on QoF now, because they really are able to sort of drill in and look at the actual live quality of care that's being delivered. But nonetheless, they might ask you about what your role is in QoF. And then they might ask you about the support that you've been given from GPs. You know, is it kind of a supportive environment that you work in? Are you able to ask for help? And yeah, final point is sort of how you redirect work given to you, which is outside of your scope of practice. Is there a mechanism for doing that? Can patients be redirected on the day and be seen on the day? Do they have to be rebooked, or are you being kind of pressurized to take on more work than really you feel comfortable doing, which we have picked up on in previous inspections, not since I started this job, but I'd see when I worked at CQC, definitely. And again, I'll repeat the same thing again. What they'll be looking for is if the process within the practice is safe and aligns with what is kind of documented, that you're being adequately overseen and supportive, and that you have a clearly defined role. That's kind of what they're looking for when they're asking these questions. That's what they're hoping to kind of drill into and ascertain. Okie dokie, that's me. Any questions following all of that? Sorry, I was just like ranting at you for a solid, 40 minutes. Sorry, guys.
Not at all, not at all. I think that was a great introduction. I think this is something that we all end up actually getting concerned about is CQC, because they are the equivalent of the GPHC if we were in community pharmacy, and we'd be sitting there thinking, oh my God, what the hell do we have to deal with on that front? So actually, it's actually a welcomed side to have that, because this is the kind of the common things that are coming through on that front. So thank you so much. There was a question about how we would get hold of those the frameworks and the RCGP. So I put that link in the chat. So the RCGP, I think it's the target toolkit on that front, and it's the target details. I put the link in there, and that's basically, I think, the introduction. But if you go down, there's like different toolkits for different areas depending on where you want to go and do your little audit on that front. So that is there. But thank you so much, Adam. It's been so helpful. Are there any other questions at all? I've got a question, probably a bit selfish, but this is me. I would probably ask you this itself on that front. Okay, hold on. So Kieran's just written, so can we pick an antibiotic? So you would pick a therapy area, Kieran. So potentially, like, are you prescribing appropriately in UTIs? Are you prescribing appropriately in chest infections? Not just one antibiotic. Have a look in the actual toolkit and see the particular areas. It says it all in there in the target toolkit on that front. So there's a lot of the pharmacists who are going down the route of, say, ACP, or are trained ACPs, and their scope is going to be a lot larger on that front, and they're going to be seeing a lot of different things on that front. Can they use just their ACP as grounds for being able to prescribe in lots of different areas?
Yes, they potentially can if that allows them to do so, but it needs to, again, still, unfortunately, there needs to be a clearly defined scope still. So even though you can't just sort of put a broad sort of title and say they can prescribe for all of these things, it needs to be very kind of clearly outlined and defined what it exactly is that they're doing. I think yeah, from inspections that have come up recently, I think we're probably talking about the same one. It really seemed to be they wanted a very, very explicit, clear scope, but that could be evidence of, they're qualified to do that. And obviously, as I said before, with your supervision and your auditing and all the rest of it, you've got then the evidence that they are kind of continue to be competent in those areas as well.
So if you're going, for example, do that, and you're going for, say, like the similar thing to, like, say, the GP update course for the year to keep up to date with everything that's going on, that could work potentially.
Yeah, that can work as well, but there still needs to be an internal mechanism as well. Yeah, but absolutely.
Oh no, I mean proving your own personal competence for what you're showing.
Yeah, absolutely. And again, I think, what I would say as well is, to sort of take the pressure off you guys, as well as CQC, very important and all the rest of it. But ultimately, it is, it's no one person's responsibility. It is the sort of practice that they're looking at. They're not looking at you individually necessarily as professionals. They are looking at how the practice sort of supports and manages you. So if there is, any issues that come up, it will likely be as a result of the kind of management of you rather than you yourself. So that's just to kind of put people a bit at ease, hopefully.
Absolutely. I will go and note those. So not from the spectrum we're talking about, but there have been other issues where people are working outside of their scopes and outside of those particular areas. And that's where it has gone to a formal thing to the GPHC where people are not working as they should be appropriately clinically. So just be aware to work within your scope and work within what your limitations are, because again, you should know what those boundaries are and working within those boundaries and how you would flag those and things like that. Because as a clinical professional ourselves, we have to have accountability for that ourselves as well. And I do know, not within South West London, but I know of pharmacists who have been referred to the GPHC for that. And there was this big thing from the PDA about how people have been suspended or struck off because of the way they practice. Same thing would happen with if you were a GP or a nurse prescriber or something, or even a nurse who is prescribing outside of the way she should be practicing. So it's not there to scare you, but it is there to actually, we may be in a different sector, but you still need to have governance and know what you're working in and the areas that you're working in and upskilling in that area.
Absolutely.
Would that be fair to say, Adam?
Yeah,
just
no,
clinically.
absolutely. Yeah, I think from a CQC perspective, again, I just get so focused on that. But yeah, I mean, I think in terms of being referred out by CQC, it's normally when there is a sort of deliberate and consistent and lack
Absolutely.
of sort of insight. It says the people who are just like, well, I think I can do this and I'm just going to keep doing this. That's when you're in real trouble, which I'm sure none of you on the call are like. So, yes. Any other questions? Sorry, Chandni.
I was going to say, and the thing I'd add to that is actually you've got the evidence of going to these actual sessions as well, where we can then, if we need to, provide certificates or whatever of attendance, where you can say, I've attended this talk as a refresher for this particular area to keep myself updated and so forth. Nisha may hate me for having to produce those certificates, but it might be a way forward, or going and actually showing that as a proof of attendance by using the Eventbrite link as well. So you're showing that you are keeping up to date, and it can be used as your clinical update on that front. So just an idea. Amazing. There's no other questions in the chat. Has anyone else got any questions from our lovely, super special and super smart CQC inspector or ex-CQC inspector? I do need to catch up with you separately though, but that'll be a different story afterwards, but we'll catch up separately from this. I don't need the 60 odd people hearing everything I need to go and say, but it's regarding a couple of PCN related things and personal things. So I will catch up with you separately though.
Nice one. Thanks a lot, guys.
Amazingly, with that, we're going to love you and leave you, and thank you so much, Adam, and we'll call you in again next year to do another update for us every year.
Happy to do so. Okay.
Amazing.
Take care, guys. See you later.
Thank you.
Bye.
Bye. Amazing. I think that was actually something that's really needed, because I think we all get a bit wrapped up, me included, where I'm thinking, oh yeah, I'm good, I'm doing the same thing, I'm doing this, I'm doing that. But actually, we don't sometimes focus on what we actually need to be thinking about on that front and what's actually important. And now you guys know what's coming. As always, we have our lovely mentee, which I'm going to get everyone just to jump on. So I'm going to try and move my lovely Nisha from this corner, just so that people can use the QR code if they want. So if we can go and get you to just scan this QR code so we can get a little bit of feedback for Adam. So if it's been relevant for you guys, if it hasn't been relevant, if you guys have found it helpful and so on and so forth. So as ever, please grab your lovely little QR codes, grab your phones. I'm going to scan it to make sure it actually works, because last time I remember it didn't work in between as well. And someone ended up saying to me, it doesn't work. How am I supposed to be doing this? So is it working so far? She says. Hello?
I haven't tried it, so just trying to get things ready.
On Johnny, 4.
Perfect.
Yeah.
People showing me love. It makes me happy. I quite like a bit of love. So if you haven't already, go on to menti.com, enter your code 45520258. If you've got a smartphone, scan the QR code, make my life easier, so we can go and actually make sure that we are going and supporting you guys. And our first question, as always, because I like to have a really simple question where people can't then go and have issues with hopefully going and trying to answer the question, which borough are you guys from? On that front, I'm going to put a really short timer of just 30 seconds on there. Where are you from? I'm not going to ask who are you, where are you from, just so we know exactly who's from where. I always find it difficult of how to answer that one, because technically Hannah and I are from everywhere. So we always trying to struggle with that. So I purposely don't answer this one on that front. But a nice, good array and good mix of people who are there. You've got another 15 odd seconds on that front.
Come on, people, there's 50 of us on this call. Can I have some more responses to reflect that number?
We've got 25. It's going in the right direction. And Peter, if you could please mute yourself, I'd be grateful. Thank you. Because I can hear some background noises. Thank you. So just another 20 odd seconds. Go on, people. It's okay. It's okay to say where you're from. We're not gonna mind on that front. The key thing for us is that we want to know that, make sure, I guess me and Hala could put the other, because technically we're from all of them. So that might be the other option for us, she says, going forward on that front. But I'm going to close it off on that one. And as ever, if we can get a little bit of feedback for our lovely Adam. 10 on responses. How was that session? Was that something that was helpful? We will always go and do new sessions where we need to, because I think that's important. And if we need to go and have more sessions, we will go and do more sessions. If it's just the update, we will do just an update to see how we're getting on that front, because there will be new things coming in thick and fast. And as an update comes up, I'll try and get Adam roped in as well, bless him, to come and do us a session on that front. But we're getting a good majority of people saying just right. A few people saying we need a few more sessions. So it'd be good if you could, those people could go and drop us some information, or drop me maybe an email, just so I can kind of make sure that when we get these sessions in, they're tailored to you guys. Some people are saying too much information, some saying too little. Again, feel free to email me or ping me an email to say what in particular that was, just so that we can then try and make sure we tailor it, or even to Nisha, and then Nisha can maybe collate all the information for us and then get back to us. So it makes it easier for us across the board to be able to make sure we're providing the right kind of things for you guys. So we've got about 30 odd responses, she says. You've got another 5 odd seconds, she says. And then I'm going to close this off and then hand over for our contraception update. So I'm going to stop sharing, she says. There you go. So Hala, I'm going to hand over to you, my love, to do the contraception update for OCPs.
Thank you, Chadney. Can everybody see my slides?
Not quite in slideshow yet.
No? Okay, let's just click it. Okay.
There you go. Perfect.
So today's presentation, the clinical presentation, is about oral combined hormonal contraception. The reason why I didn't want to go into a wider side of contraception, because it's such a wide topic with so many different options. So today's presentation is just on the combined oral, which we'll find quite a lot of our patients are on this type of contraception. So it's important to understand how it works, options out there, the risks, how to deal with those cautions and side effects. How would you understand which brand is better for which symptoms or for which patients? So the main components of a combined oral contraception is the estrogen and progestogen. The majority of the combined have, and the transdermal and the vaginal contraception, they have estrogen as ethinyl estradiol. It comes in 20 microgram and 35 microgram. It's a synthetic estrogen. The progestogen part of the contraception is different. It comes from synthetic steroids designed to have some of the properties of the progesterone. Now, the main effect of the estrogen in the contraceptive pill is to stop the ovulation, and that's by negative feedback to the luteinizing hormone and follicular stimulating hormone. The progestogen side of things is it helps to suppress the ovulation. It also prevents the overproliferation of the endometrium, which happens when we have an ovulation. Newer progestogen were developed also to have fewer androgenic and glucocorticoid effect. So some of these could be favorable in anti-mineralic corticosteroid effect. So as I mentioned, that there are different types or families of progestogens, and they look at them as generations. Now, the newer progestogens in combined hormonal contraception, they work with the ethinyl estradiol, and they are looked at, they have higher or greater risk of developing VTE than the older generation. So if we look at the different classes of the generations of the progestogens, there's the northisterone, levonorgestrel, disogestrel, gestodine, norgestine, and the newer as the drospirenone, deonogest, normogestrel acetate. Sorry, I'm a bit thirsty because I'm fasting, so you're going to have to bear with me if I go slow. So as I said, the main mechanism of action is to prevent ovulation, and that is by acting on the hypothalamus-pituitary ovarian axis to suppress the luteinizing hormone and follicle stimulating hormone. I'll show you the graph in a minute, and that will help to stop ovulation. Changes in the cervical mucus, endometrium, and tubular motility results from the progestogen side of the combine can also contribute to have an effective contraception. So this slide, I think, is important. If you ever deal with anything that is women related, it's important to kind of like have this slide in front of you, print it, laminate it, because once you understand the cycle and you understand the levels of the different hormones at different times of the cycle, it's so much easier to give the right advice. So if you can see that the luteinizing hormone and the follicle stimulating hormone will help the eruption of the ovulation and the producing of the ovum. And that's when the estrogen will drop and it goes up again. So what we're trying to do with the combined hormonal is to have a negative feedback so we don't have this stage of the ovulation. So now we have monophasic and multiphasic combined oral contraceptions. What that means is the amount of estrogen in each pill. If it's stable, is the same in each pill of the month, then that is a monophasic pill. If it's variable, where you have it goes low and then go high and low and high again, they're trying to mimic the natural ovulation cycle that you just saw on the previous slide. Now, research has shown that there is no true evidence that the multiphasic is better than the monophasic. And the guidelines developed group recommends that the monophasic combined oral contraceptive should be the first line rather than the multiphasic. Now, next thing is we look at the holiday-free interval where the patients or the woman has no hormone within those days. So there's a continuous use of combined hormonal contraceptions with no holiday-free interval. There is extended use with a smaller or shorter holiday-free interval. And there's the ones where we can take it where it is as prescribed, where it is 21 days pill, active pill, and 7 days of holiday-free. Now, all the licenses of the drugs are prescribed as 21+7. So you need to advise patients if you're going to go and prescribe it on a continuous or extended use, then you need to let them know that this is outside the prescribing license of the product. Now, if you look at the table in the on the slide, so the standard use, as I said, is 21 days active pill, 1 ring or 3 patches, and then we have a holiday for 7 days. Now, shortened hormone-free intervals is when you have 21 days, 1 ring, and you only reduce it to 4 days. Why are we trying to do that? Is we're trying to reduce the risk of ovulation or escaped ovulation that can happen during those 7 days. So that's the whole point why we're trying to reduce that period. Also, if I'll come back also to why we do that in a minute. If we have also extended use, which is a tricyclic, where they have 3 cycles, continuous pills or rings or patches, and then after those 3 months, they will have 4 to 7 days of a holiday-free interval. So that's an extended use. Flexible extended use is if they use it more than 21 days, and then whether that's a patch, a ring, or a tablet, and that once they start to have a breakthrough bleeding, that's where they take a 4-day holiday. Continuous use is when they take it continuously with no holidays at all. Now, starting combined hormonal contraceptions and requirement for additional contraceptive precaution. So if you look at the table, there's only 2 places where they need to take extra precaution, and that is when they do not need to take any extra precaution, and that's if they have a period, they having a natural menstrual cycle, and they starting the pill up to or including the 5 days period. So that is when they don't need to take extra precaution. And the other one is if they have had an abortion, ectopic pregnancy, or gestational trophoblastic disease, up to including day 5 following treatment, then that is, again, they don't need to take any extra precaution. All the rest of the cases, they will need to take extra precaution, which is barrier or abstain. And they also tell you if you need to do a urine high specified urine pregnancy test in these cases. Now, if we are trying to switch hormonal contraception from a different type of contraception, now, if a patient is already on a combined hormonal contraception, they can start the day after last active combined contraceptions, CVR or CTP. They don't need any further requirement. It's almost like they're taking it continuously. So they do not need to take any further precaution. If a patient is on a traditional POP, which is progestogen only pill, sorry, Andrea, you need to just bear with me. So if they are on a traditional POP, now the way the progestogen only pill works is it increases thickness of the cervix and the endometrium. So it reduces the penetration of semen into the uterus and prevents ovulation. So because of the change of mechanism of action of the medication and how it causes contraception and prevention of pregnancy, the patient will need to take extra precaution for 7 days, because we are trying now to suppress any ovulation that could happen. So they need to have a 7-day protection. If they are on a progestogen only anti-inflammatory, anti-ovulatory method, which is disogestrel, injectable or implant, and they're changing to a combined, they will need to start a day after the last time they took these medication. Now, these medications are designed to suppress ovulation. So if you look at it, technically they work the same as a combined hormonal, and that's why you look at it as like it's almost like a continuation. So they can continue with a combined oral contraception and they don't need to take any extra precaution. If the patient has intrauterine with progestogen on it, like the Mirena coil, then moving to a combined contraception, then again they can start it at any time. But again, because we're moving from a different method of non-ovulatory prevention treatment to an ovulatory, so we need to give them a 7-day precaution period, or where they take extra precaution. So the effectiveness of oral combined contraception. Weight has absolutely no effect on how effective a oral combined hormonal contraception is, because they will still absorb the same amount technically from their gut. However, having said that, patients who had bariatric surgery can have a reduced absorption rate. So the guideline discussing group would recommend that women who've had bariatric surgery should be advised that potential reduced effectiveness of the combined oral contraception. They should look at a non-oral contraception to be a safe and effective contraceptive method. Also, severe diarrhea and vomiting after taking a pill can affect the effectiveness of the contraception, especially if it's a prolonged period of time. There is a slide that will show you if they missed doses. And I think that is an important slide to look for when you are discussing with patients. Drug interactions is another important aspect with the oral contraception. If a patient is taking an enzyme-inducing drug, so women should be informed that their contraceptive effectiveness could be jeopardized, and for 28 days after stopping. So it's important that the women are aware of this. They take extra precaution if they are on those medication. You might want to discuss with them long-term or long-acting contraception. Lamotrigine should also be advised that oral contraceptives will interact with lamotrigine. So the results will reduce seizures control or lamotrigine toxicity, and the risk of using combined hormonal contraceptives could outweigh the benefits. So it's really important to understand what they're having. Are they having it for seizures? Is it for pain, or is it for mood stabilization? And then you need to give the appropriate advice accordingly. So if they're having it for pain, not for pain, for mental health, it's different than when they're having it for anti-epileptic medication. So you need to really make a clinical decision on the best medication to give if they are on lamotrigine for seizure control. Antibiotics. So normally additional precaution is not needed unless that antibiotic is enzyme inducing. So I don't know, many years ago, we used to say for women who were taking amoxicillin that you need to take extra precaution. I think there was one actress who said that she claimed she had amoxicillin and the pharmacist didn't tell her that it can affect the contraception, and then she ended up being pregnant and the pharmacist being sued. So there was a big case about it, probably about 15 years ago. But it's not the case. It's only the enzyme inducing antibiotics that can have an impact on the contraception. Progestogen receptor modulators, and that is the Pharmacist. So women should be advised to wait 5 days after taking the UPA, because if they take it within that period of time, they can affect the effect of the Pharmacist rather than so the emergency contraception will be failed. So they need to wait for 5 days after finishing the Pharmacist, and then they need to take it as they're taking it as a first or initiating a contraception. So they need to take it at day 1, abstain from sex, or take extra precaution for the first 7 days.
I've got a question, Hala, if you don't mind me asking quickly.
Sure.
So in terms of if you've got a patient who's on Orlistat, how would you go and let that person know in terms of the absorption of the oral contraception in itself? I would have thought for myself that I would just give it 3 hours separate from the Orlistat to allow it to have gastric transition on that way, and then maybe take it at a time separate. But is there another way around it?
So if they take the medication, so if they take the contraception at least 4 hours window, so we know that the effect of the Orlistat has cleared off from the guts, and then they can take the medication without affecting the absorption or being excreted fast through the guts, then that gives you a more and it depends again of are they stable on their combined contraception, and are you starting the Orlistat? So you need to advise them about the possibility that if they take it at the same time, the dosing of the combined oral contraception might not be effective. So it's important to leave at least, I'd say, 4 hours window to ensure that they're not affecting the absorption of the contraception.
I always say take it at night before you go to bed to make life easier, because then you're not eating, hopefully, if you're a normal patient.
Exactly.
You're not waking
You're
up in the middle of
eating.
the night to eat and take another Orlistat.
Yeah, exactly. So the Orlistat will be with food, while this one will be without. And it depends if they're having intermittent fasting, they can take it in the morning because that will help them reduce weight as well. So it depends on the lifestyle of the patient, and then you discuss when is the best time for them to take this medication.
Amazing. And in terms of when you're looking at patients who are on HRT or going on to HRT, is oral contraception, in terms of oral contraceptions, is there a particular one that tends to be better?
So when we're going to look at HRT, most probably the women are in their 40s. And the recommendation is to go for progestogen only. Okay, so we do not go for the combined when women are over 40 due to increased risk of thromboembolism. So yeah, so POP is your go-to. Mirena coil is an even better choice because it will provide the progesterone side of HRT.
Perfect. That's all our questions. Can please carry on.
So what are the risks? Now, as I said, there is the increased risk of VTE, and now levogestrel, northisterone, and norgestimate are considered to have the lower risk. So when we talk about combined contraception, we have the estrogen and progesterone. Now, the estrogen side of things is the same, but the progesterone that along the years they've tried to find a progesterone that reduces certain side effects that come with the combined oral contraception. So the change of the combination can increase the potency of the estrogen to cause clots. So the clots are always related to the estrogen component of a contraception or an HRT. But it is the other side, almost the toxic side of the progesterone, the toxic partner, whatever way you want to put it, is the one that will bring up that effect of the estrogen. So used by women with significant additional risk. So women who have high risk of developing a clot, which is hypertension, cardiovascular disease, diabetes, high BMI, and the reason why high BMI, we know that there's increased risk of clots, and that's why we do not prescribe combined hormonal contraception for those ladies. It's not because of the estrogen not being absorbed or not being effective, but because they're high risk of developing a clot. Smoking is also increases the risk. Dyslipidemia, women with migraines with aura or without aura, especially if it comes with the combined hormonal contraception. So these type of women, you need to make sure that you're aware of their high risk of developing a clot, and that you should try to avoid combined oral contraception as much as possible for that cohort of ladies. Now, breast cancer, there's a small risk of a breast cancer with the combined oral. Normally reduces after stopping, but do not give it for anyone who has a BRCA gene positive or an active breast cancer. Cervical cancer, also the risk is small and reduces after stopping. So what are the benefits of the combined oral contraceptive? So it gives a light and predictable bleeding pattern, less dysmenorrhea, improves acne, manages symptoms of polycystic ovary symptoms, endometriosis, and menopause, can be used to the age of 50. I know it says up to the age of 50, but as we said, the advice is not to use it over the age of 40. Reduces the risk of endometrial cancer because it has progesterone with it, ovarian cancer, and colorectal cancer. We don't know how it affects the colorectal cancer. So the absolute contraindication, which is UK MEC4, if blood pressure is high, and that's 160/100, and that's why it's important that when we do the review, we have an up-to-date blood pressure reading. As I said, current breast cancer. Smoking, if they're smoking more than 15 cigarettes and are more than 35 years old, so we do not prescribe them that. Current vascular disease, because they're already at risk. History of VTE or known thrombogenic mutation, like factor V latent prothrombin mutation. Migraine with aura, because migraine with aura has shown that the patients are at increased risk of strokes. If their BMI is more than 35, then it's UK MEC3 and should only be initiated by specialist. So when you look at the BMI 35, look at other risk factors like smoking, a history of VTE, blood pressure. All of those things should be taken into a consideration and discussed with patients. So choosing the type and formulation of combined oral contraception. So all of them, they contain what's equal to or under the 30 microgram of ethinyl estriol in combination with levonorgestrel or northisterone. And these two types of progesterone are the most safest ones to initiate the patients on to reduce the risk of having VTE. Now, this is the misrule slide, and I think it's important for you to keep a copy of this slide because it gives you different scenarios. Now, I will just go through it. Everything is in there in details, and hopefully it will be self-explanatory. So it's very important to look at where they are within their cycle of the combined contraception. So if they take out the blister, that you can count hopefully how many days through they are. So the first question, has the holiday free been extended more than 7 days? If the answer is yes, then and if an IPSI happened, then they can consider emergency contraception because they could have exceeded that holiday. They should be on contraception to restart. So there's a chance of escaped ovulation, so they need to have an OPSI. And then they need to take all the missing pill ASAP, continue the rest of the pack, use condom or abstain for 7 days. And also they can do a pregnancy test. If the holiday free has not been extended, if they missed more than 2 or more pills within more than 72 hours since last pill was taken. Now, this is where we jump into 2 parts. If they are on week 1 after hormone-free interval, consider emergency contraception if OPSI has occurred in the past week or holiday-free interval. So you might want to start to take the emergency contraception, and then they can take the pill and condom, and then avoid abstain for 7 days. If that happened on week 2 or 3 after the hormonal free interval, so that means there's enough estrogen in the blood to cause negative feedback for ovulation. That means emergency contraception is not required. Just take the missing pill ASAP and continue taking the remaining pill in the pack. If more pills missed in the 7 days prior to the schedule, omit the holiday-free interval, use a barrier contraception method, and avoid sex for 7 days. Now, if one missed pill is 48 to 72 hours after last pill taken, emergency contraception is not required. Take missed pill ASAP, continue rest of the pack, no additional precautions is needed. So it's very much dependent on how much estrogen is there in the blood, and that depends on where you are in the cycle, and accordingly you make a decision on where the patient needs to do. So I think this is important to keep with the pharmacist, because doctors sometimes ask. Dianet. Now, Dianet once upon a time was a very popular option for the younger women because of acne. So it is licensed for use in women of productive age for the treatment of androgen-sensitive skin conditions like severe acne and hirsutism. It should only be used when topical treatment and systemic antibiotics have failed. It is an effective contraceptive, but should not be used as the sole contraceptive combined. The reason why, because it is comparable to generation 3 and 4, where there is increased risk of BTE. Today I had a lady who started, who was on Dianet, and it was prescribed again by a GP. She was 17-year-old, sexually active, and when I asked her why she is on Dianet, she said she started it in Ukraine. She had irregular periods. They're quite heavy and painful, and that's why she started it. She had no history of acne, no hirsutism. So I discussed with her the risk, and we changed it to a different contraceptive pill. So it might be worth running an audit to see your Dianet. Is it being prescribed per guidelines or not? Now, I tried to, for me, when I started doing women health, having so many different brands of contraceptive pills out there was so confusing. You don't know why they're choosing this, why this one, not the other. So I thought I'll give you a table of the different groups and the pros and cons for each brand. Why do they think this one will be more effective over the other? So group 1 is the lowest risk of thrombosis. So these are the first and second generation of progestogen. They normally contain 30 microgram of ethinyl estradiol and 150 microgram of levonorgestrel. They have the lowest risk of thrombosis, but they can cause oily hair, skin, loss of libido, or bloating. The main brands are the ones on the right, which is Revigadon, Macrogynon 30, Levest, Overnet, and Maxine. Group 2, possibly better for acne and for bloating, so less greasy skin and hair. They contain 30 microgram again of the ethinyl estradiol. However, the progestogen is 250 microgram of norgestimate, or 30 microgram of ethinyl estradiol with 150 of the disogestrel. So as we said, it's better for acne and bloating, but might be less good if they suffer from nausea or breast tenderness. Despite the fact that they both have the same amount of estrogen, it's the effect of the progestogen that will have exacerbate the effect of the estrogen in the combination. These include Celesk, Celique, and Lizina. Group 3, possibly better for nausea, breast tenderness, and breakthrough bleeding. They contain 30 microgram of ethinyl estradiol. As you can see, most of them contain that much. And 75 microgram of the gistidine. Now, as I said, they are better for nausea, breast tenderness, help if they had breakthrough bleeding on the other pill. But they contain the neuroprogestogen, so they have a slightly higher but still very small risk of thrombosis than the pill in group 1, and that one like Coumadin and Milinet. Group 4, possibly better for nausea and breast tenderness. They contain a lower estrogen of 20 microgram in each rather than 30 in the other pills. And so that's why they have less breast tenderness and nausea effect. Now the cons of these things, some people have breakthrough bleeding because the estrogen level is not enough, so they might experience breakthrough bleeding. It might be a good idea to start this one for the older generations or the older women when they come, because they don't need as much estrogen. So that is one option that we can think of for the use of a lower estrogen level. So they have the neuroprogestogen again, so slightly higher risk of thrombosis. And these are the brands on the right. Group 5 marketed as better for acne and bloating, and they contain, again, 30 microgram or 0.30 milligram of ethinyl estradiol, and they contain 3 milligrams of drospirenone, which is a newer generation. They have been marketed as improving acne and bloating, but there is not convincing evidence to support this claim. They do carry the higher risk of thrombosis, and these are the Yasmin and Lucette. Now, group 6 is the ones that have non-active pills, and that is the Macrogynon 30 ED. So most of this information was from the UK MEC, where you can access it there, and the FSRH as well. There's lots and lots of information about contraception, but I hope that these slides will provide almost like a small reference for you to use on day-to-day when you're doing contraceptive reviews with your patients. Any questions?
Thank you so much, Hella. I think that's been really helpful on that front, to be honest, because actually there are things that we sit there and we worry about. So there was a question that came through, which I've answered in the chat to try and make life easier for you. Following on from the HRT one, can a patient take a pop and HRT that contains obviously progesterone? Would it be too much? I managed to find the little table from the FSRH to make your life easier, and I put it in the chat. Yes, you can, because they're very small amounts to make life easier. And again, on that also it goes and shows the other different things that you can use which are safe in terms of contraception alongside or not. And it clearly says do not use in combination with the HRT in itself on that front. So I did pop that in the chat to try and make your life a bit easier, she says.
So I think it's important just to understand that, as it says, hormonal replacement therapy. So I mentioned this in previous presentations. If the normal level or the lowest level of estrogen is that much in a woman, and when she's in menopause, that level drops to here. Now, this difference in the levels is what causes those symptoms, the vasomotor symptoms. So the HRT is literally trying to bring that up to here. So if I look back to, let's just go to
your lovely picture.
My lovely picture.
That one.
That one, yeah. So if you look at, can you still see it?
Yes.
Okay, so if you look at the levels here of the estrogen, if that is where is the lowest amount of estrogen in the blood to keep a woman vasomotor free, and this is the one that is dropping, and we're trying to bring it, with the HRT, we're trying to go back to that line of the yellow line of the estrogen level. So it's not providing contraception. We're literally just stopping it up to avoid those symptoms. So it doesn't work at all like a contraception. And that's where we need to add a contraceptive method for those women who are through perimenopause, 1 or 2 years, depending on their age. I hope that makes sense.
It does to me. But again, we will be doing HRT at a later session as well. So we'll be using both while breaking on that one as well. God help us. So thank you. I haven't got any other questions. We have got a few people who've said they've sent their apologies because they have to leave. They've got clinics,
Sure.
which totally understandable. Key thing that I'm going to add in is obviously these sessions are only as good as obviously attendance, and they are there to help you guys to show your confidence, competence, that kind of side. So you can put it on your scope of practice, like how Adam had said. The other thing I'm going to also go and pop in that as well is that do try and stay for them as long as you can, because obviously you get, the more you get at them, the better they are for all of us as well. What I will then go back to, as always, because that's what I tend to do, is we go back to our lovely mentee, she says, because then it helps us to get a bit of feedback going forward on how everyone tends to find. And please do make sure before other people start logging off that you sign up on the Eventbrite going forward, because we need to tally. So Higher Education England, so HEE, have said very specifically that we can only get funding if we can prove who's coming and who's actually interesting. That includes if you want the recording. So if you want the recording going forward and to be emailed out to you, you do need to sign up, even if you can't attend, just so that we've got your name on a list to say you are interested in these particular sessions going forward. So if you're forwarding the links going forward, we can't send you those recordings, and we don't have that on the list to say you attended today or were interested in attending going forward. So please make sure that you do go and actually register on the Eventbrite going forward. And I know that Nisha very kindly sends those requests out every single month. I try and put it in the group for the Telegram. Hala did it this time because I've been completely mental with quaff and everything else going through. But please make sure you do go and register. And if you'd like to join our Telegram so you get those reminders on your phone, we can put a link for that in the next email as well that comes out with everything, so everyone has it. So hopefully you still all got your mentee open, she says, on that front. If you haven't, where have you been on that front? So our next question on that front, and I actually found that really informative, Hala, so thank you so much. It's a great refresher to have. Although we go and do it day in, day out, it's nice to have someone actually go and say to you that actually you're doing the right thing, and it makes life a little bit easier.
It's just a reminder sometimes that these are the things you needed to look out for. This is why we do it this way. Just have a reference at hand so you know what to go back to.
Absolutely. And I think that as it was said very aptly, that people would very much like your slides. So please do circulate them on that front. And I think it will probably tie in and make more sense when we do the HRT one as well, because again, that tends to explain the whole cycle for the women in itself on that front. Apologies, we can't go through that for men, for menopause for men. It's not something we can go and divulge on that front.
I think maybe having another session on the progestogen and the long acting contraception might be a good idea as well, but hopefully that will be for the future.
that would definitely be something for the future. I think would be going and doing as a revisit session would be probably really good and really helpful. So again, with the amount of us that there are, if we can get you on there to go and join Menti, so join menti.com, she says, and use the code 45520258. Hopefully you guys have kept it all on, because I always encourage you guys to try and keep it on so it makes it easier for us to be able to go and get you guys' feedback about how it was, and about obviously if there's any other bits and bobs that we guys can support you with. So we've had about 20 odd people go and give us some love and let us know, and we've had a welcome saying it was just right. Some people saying we need a few more sessions, which I think is fair enough, because I think there will always be other people who would appreciate a bit more information on that front, and I'm not going to stand away from that. It's always good to have a refresher on that front going forward. So and bless you for doing it, especially while you are fasting as well. That can't be easy. But I purposely didn't go and drink in my video. I turned off the video if I needed to go and do anything, because I was like, I'm not going to do that. So we've got another about 25 odd seconds left. So if you haven't already, jump back on the Menti, give us that information and let us know how that session was. Hala will be circulating those
yes, I'll send it now so I don't forget. Yeah.
And also if you've done the Eventbrite, you'll get a copy of the slides as well. That's how we're going to have to go and buy and doing it. And it's not from us, it's because of Higher Education England and the way that they want to go and propose these sessions. Now, for those who are here on that front, we're going to go and use the next few sessions for CPD and supervision related. So reflective practice, thinking about what's going on and give it, because everyone had said very much that they wanted us to go back to these sessions. So we're going to give them to you guys on that front, and we're going to make them as interactive and helpful as we can. So reflecting on today's presentations, how do you feel about supporting patients with clinical and actually also the non-clinical areas covered today? So if you can write CQC this, contraception this, so we can then go and get a bit of a response back. And this is then the idea would be is to get a bit of your feedback and start reflecting about on the things that you guys have actually learned about, and thinking about areas that actually you may need to go and target a bit more about, a bit more support on, but that's a bit later on in those questions later on. So how do you feel about what you've learned today and what you've been going on? And I've probably realized I have turned on responses, so you should be getting responses on that front. So buy in and tell us. So you have a good starting point for CQC, and for COC, good refresher. Amazing. That's a great thing to this. I thought of keeping records of my own competence to feel confident with CQC. Absolutely. I think that's a great thing, because I think that's where we can all have our own little portfolio. I have a governance folder. You don't want to see my governance folder, but there you go on that front. But CQC will make a start on areas discussed and created a folder, which I'll use more now. Amazing. Contraception, happy to make more of a start now. Amazing. So really glad to hear that. CHC was great, really great refresher. We'll need to read more about good training to get me started. Amazing. So good training, which we can probably go and say. So you've got like the NB medical sessions that you can probably join. Red Whale do a great update as well if you want kind of new sessions as well on that front. Definitely helpful to know what is out there for COC. Would love more on POP. Good idea to make a portfolio folder as well. We're all about giving you guys ideas. If we can't give you ideas, that's a different story, but we're all about giving you ideas to try and benefit your practice on that front. CQC, really helpful that we're all on the right page. Absolutely. And I think that's a really big deal. Helpful is confirming responsibility of practice for PCM prescribers and pacing our patients. Pill helps to contribute on scope of practice. Absolutely. More confident. We always want to hear people are more confident on that front. Good CQC session to keep us on our toes. Contraception need to revisit, but great session. Completely agree. And I think that's good, because at least you're identifying areas that you can then go and benefit from going and revisiting and upskilling on that front. And again, when we do our next session on HRT, hopefully with the different influx of hormones and issues on that front, hopefully that will make it easier as well. Keep them coming. We've got another about 20 odd seconds on there. So clinical, good refresher. Non-clinical, we be strict on better record keeping. Absolutely. Look at prescribing policies and amend and follow them if needed. Completely agree. I'm seeing more flurries coming in, so I'm gonna go and give a bit more longer for this countdown on that front, just so that people have a little bit longer in case they're thinking about it. More confident, good refresher of knowledge. Amazing on that front. So it helps on that front. And I think especially with the CQC, I think it was nice having someone who is an ex-inspector actually talk to us and tell us the kind of things that come through. So really helpful on that front. And actually, I'm going to add in there, really helpful just to go through someone who's been through the CQC inspection as well, to add in and hopefully give you a bit of advice. So the portfolio was something that we came up with that thought actually really worked really well. And then good CQC update. Both topics were good learning starting points. Miss Pill slide was very good. Well done, Hala. Contraceptive was great. Need to get good training to get start. Also good idea to make portfolio for CQC. Amazing. Well, I'm glad that that was hopefully helpful for a reflective practice side. The next question, so planning. After this session, what do you guys want to do more of? What are you going to do differently? How and what are you going to do to make that forward? So again, split it up. CQC, I think we've got that people are going to make portfolio, but feel free to write that again. And for contraceptive side, does this make you feel ready to get on out there and to go and do more in terms of contraceptives and start or be doing those reviews for those pill checks, which sound like they can be quite scary? You can enter a word, you can enter a bit of an essay, enter a few different things. So I think this is a little bubble thing that comes up on that front. So you can go in, or a bit of a word cloud thing, I think, if I remember. So what are you going to do differently on that front? So it makes it easier for all of us on that front. It might give some people a bit of an idea of what they feel that they need to go and do as well. I think I remember doing one of Hala's talks very early on, and I went back and I looked at the FSRH guidance in more detail on that front. And I actually printed off a lot of those pages that she'd said, so it made it easier.
It's so much easier with the FSRH. They have so many different documentations, nicely laid out, good information that you can use. And it depends on, you know, they categorize it, whether it's weight based, whether it is hormonal based. So it's a really good website to go and familiarize yourself with. Just in case you have a query, look at the different things that you can find on that website, because it is the guidelines that most GPs are reliant on.
Well, actually saying that, I actually had a really nice I had a really interesting question, which I hadn't revisited for a while, about bleeding protocols and things like that. And can we use northistrone alongside the different pills, and should we double up the pop? Should we do this? Should we do that? And actually there's a really nice document on the FSRH kind of side, which then allows you to go and actually think about that. So I actually just ended up going and having a read through for that to refresh my own knowledge. But actually at the same time, pass it on to the GP, so it boosts their knowledge. So we're getting lots of different things coming in. So evidence of supervision, go and make sure you add in a plan for the financial. Oh, I want to know what that means. Add a plan for financial. I want to be involved if it's anything to do with money. So think about your CQC protocols, look at different florries that are out there. Absolutely. Check all your policies, reflect more. I think that's a really nice one. Reflect more about what you're doing. Scope to be given to reception. So for people who are going to be giving a scope to reception, maybe what I tend to go and do is a clear cut, as on my list, I've given them I don't deal with this list. I don't deal with this. I don't review these patients, like how the A&Ps will go and give out for patients they will see or they won't see on that front. So that actually really helps as well with their practice as well. So speak with the partners, absolutely, because you don't want to be putting yourself in a difficult position on that front. Start your portfolio, amazing. Another person's written the portfolio side, spot on. So do things that work well for you on that front. We've had 14 responses, which are great. So the more responses that we get, the better, because again, these will go and help other people, hopefully, who are out there who are thinking along the same lines of what do I need to be actually doing. Hannah, anything else you picked up?
Yeah, actually, I just remember there was a question that we didn't answer. If somebody is on a medication and we're reviewing that medication, it has been diagnosed and initiated by a doctor, and it's outside of our competence area, are we okay to issue it? Now, the way I look at things, if it is a medication, for example, if you're an asthma competent non-medical prescriber and the medication is for hypertension, it's well documented. The guidelines are crisp clear. The patient is on it. You've done the monitoring, then that's fine. You can prescribe it. But if a patient has been initiated a more like Entresto and has not been reviewed, then no, I will not prescribe it. Same goes with other like high-risk medication. Make a clinical decision and make the partners or the doctors or the GPs know that you're not comfortable to prescribe these medication. I think everybody likes a safe clinician, but not somebody who's lazy. So as long as you make it sure that they understand why you're not prescribing these medication, if you're forwarding it to one of the doctors, tell them that this medication just initiated, you're not comfortable, you have reviewed it, it's fine from your side as a clinical pharmacist screening the prescription, but you're not happy to prescribe it. So there's a difference between clinical screening and prescribing. Hope that answers that question.
Absolutely. And I think that's the key thing. I think I tried to answer that. I don't know whether I covered that. I think I covered a different question about the similar sort of thing. So I may have missed that. So apologies on that front. So our final kind of question, she says on that front, as a part of a team, because we all work part of a team on that front, how can you use your knowledge from today's session to enhance the safety of prescribing in these clinical areas? But actually, I'm also going to say in a CQC perspective, because the high-risk drug medicines searches and the searches that are there for example, picking up, say, CKD that's been missed, which should hopefully kick in with the CKD les and all the CKD stuff that we're doing across Southwest London. What are you going to do as part of that kind of stuff? In terms of a robust protocol, getting the practices involved. So anyone who would have probably works with me has probably saw I sent an email out already saying this needs to be part of a robust protocol that the practices need to initiate, because I think that it's important that practices take an ownership as well.
I think we're not there to save the practices. I think you need to understand you have a role in there, which is a very important role, but your role is not to save all the prescribing issues for the practice. It's a teamwork. You need to get everybody on board, and that's why I think Adam said when you look at the policy, do a small kind of like snap audit and to see the prescribers, are they following your guidelines? And if not, then do you need to change the guidelines to fit the prescribers, or do the prescribers need to fit the guidelines? So it's a teamwork. You can't carry all those burdens on your shoulder by yourself.
I'm going to chase up that non-medical prescribers policy that I've actually written for our PCN and make sure it gets authorized and sent out to practices to make our IPs feel a bit more comfortable is my action that I need to go and do going forward. So we've got review current searches and streamline the process. Absolutely. Look and update the protocol, discuss the process at a team meeting so everyone's aware of what needs to be done, so everyone's on the same page. Absolutely, I think that's a great one, because it's a team approach. It's about getting that support from everybody. It's not just one person running the whole show on that front. Yes, we have a role to play in that and picking up those people who have been missed, absolutely, but it shouldn't be a robust system by itself on that front. They should have another system in place. Anything else from anyone else? I don't know how many people are left on the actual session, Hala, because I can't see any of that.
So we are 41 in total, but I'm not sure what's going with the writing of their different responses.
Feel free to put it in the chat. If you don't want to use Menti, put it in the chat, and I'm sure Hala can read those out as well. Because then at least we're then engaging the responses back on that front. And we're getting from people. We just try and use Menti so it's anonymous. So everyone can then go and use it and it stays anonymous for everybody on that front. I'm going to make
just wanted to ask, what is next session, the next forum? What are the topics for the next forum? Just so people are aware if they're still listening to this.
It's mental health, Hala, on the 24th of April.
Okay, so mental health is a massive, massive topic that a lot of you wanted to know more about.
And I think we're planning to look at depression, anxiety. Caroline Mollison's coming to go and
she's a
support
fantastic speaker, really, really confident and well knowledgeable in her area. So she's an asset to the team at St. George's. So really, really try to make time to join in.
Especially for those people who feel a bit unsure about looking at anxiety, depression, mental health reviews and things like that. It will definitely help to benefit that. So come on, guys, what action are you guys going to take? You got more than 2 of you out there for definite. Come on, give us a couple of answers on that front. What are you going to do? How are you going to progress this? Because you guys said you wanted supervision. We're giving you guys the part of supervision going forward on that front. And this is part of it in terms of looking at our CPD and reflecting on our practice and reflecting on what we've done. So what are you going to do going forward? We've got 40 odd seconds and people don't want to talk to us. Okay. I realize that it's important to involve GPs. Absolutely. Review the current protocols and ensure enough proof is available for CQC. Great idea. I think that's a great idea going forward on that front. So
it's and I think it's understanding that it's not just for CQC purposes that we do these things. The CQC's job is to ensure that there's a safe environment to provide care for patients. And if we do that as a daily habit, then eventually you will start to look at things from a different perspective and you will be taking initiatives to do things in a proper way. Yes, it will always mean extra work, but I think as long as you try to discuss with the partners that this is for a better outcome, a safer outcome for the patients that we are looking after, then hopefully they can all join in into that mantra.
Absolutely. Someone's going to talk to me. So
I know, as always.
Fine. Feel free to talk to me. I can listen, I can talk. We can do that. That's absolutely fine. And then I think that's just the end of it. And hopefully, as Hala has said, we look forward to seeing you guys in the next session on that front. So I'm going to stop sharing. She says, Nisha, I can see you're burning and wanting to say something.
No, I don't want to say anything.
Shall we stop the recording?
Yes.
Thank you.
Perfect. So I think the next session we've got